Hi, everyone, and thank you for joining us this afternoon for this very important conversation, especially during Breast Cancer Awareness Month. I'm Reba Hollingsworth with CBS 6. I will be your moderator today. We have an expert panel that you can see right here, and they will answer your questions. I will ask each panelist a few questions, and then the panelists will answer your questions. Just write your comments in the comment section, and we'll get those questions answered. We are thrilled to work with the American Cancer Society for this Breast Health Equity Summit, the first ever, and the representatives from the American Cancer Society will also be answering your questions as well when you write them down. Focusing on health equity is not new to the American Cancer Society. In fact, it's embedded in almost everything that we do. The COVID-19 pandemic has exacerbated disparities among most a vulnerable population. Cancer is a disease that affects everyone, but it doesn't affect everyone equally, and health disparities adversely affect different groups of people. Now, today we are coming together because our families, our friends, our colleagues, and communities are counting on us. We're hosting this virtual Breast Health Equity Summit to educate everyone and to influence policy decisions for meaningful, sustainable change. And before we get started, we want to thank all of our sponsors out there who really helped us put all this together, because we know we're living in a very different world right now. But our presenting sponsors, Virginia Women's Center and Dominion Imaging, our gold sponsors, Langley Federal Credit Union, silver sponsors, Myriad and Centera, our bronze sponsor, Carillion and Humana, and our media sponsor, WTVR CBS 6. Virginia Women's Center and Dominion Imaging are community partners who support the American Cancer Society in developing this inaugural program. And Dr. Keith Burkle of Virginia Women's Center, who is our presenting sponsor, would like to say a few words. Dr. Burkle.
Thank you so much, Reba. Collaboration is key to impacting change. So together with our life-saving radiology partner, Dominion Imaging, Virginia Women's Center is proud to sponsor and welcome everyone to the inaugural American Cancer Society's Breast Health Equity Summit. This important event will focus on the state of breast health care and access across Virginia. Listening to and leaning on the experience of state and healthcare leaders, today's discussion will assess where we're succeeding and where we're falling short with breast health care in the Commonwealth. Black women have a lower risk of developing breast cancer in their lifetime, but a significantly higher death rate. Black women die as a result of breast cancer 41% more than white women. This number is staggering, and we have to do better. We owe it to these women to bridge the gap in their care and restore their faith in medicine. Several months ago, we at Virginia Women's Center started an important diversity and inclusion conversation. We reached out to African American community healthcare leaders to hear firsthand the healthcare challenges and access issues Black women face across RVA. And these conversations have launched a series of training sessions with our providers and staff. While we know there's more to be done, we're confident we're on the right path to better understand how best to care for women of color in Central Virginia. So when the American Cancer Society contacted Virginia Women's Center regarding the sponsorship of today's Breast Health Equity Summit, we, together with our radiology partner, Dominion Imaging, were delighted to accept. We believe that access to the latest technology, tomosynthesis, more commonly known as 3D mammography, is of pivotal importance if we're going to reduce the number of Black women dying from breast cancer each year. According to our partner, the medical director at Dominion Imaging, Dr. Ronnie Talukdar, size matters. The survival rate of breast cancer directly correlates with the size of cancer. The smaller the tumor, the greater the chance of survival. So finding cancer early can ultimately mean the difference between life and death. And 3D technology plays a critical role in finding smaller cancers earlier when they're most likely to be curable. So today, we're going to hear from experts regarding research findings, mentorship programs, and what we can do to close the gap in care. We're excited for an impactful and interactive experience, and thank you for joining us for this important conversation.
Wealth of knowledge right here. Thank you, Dr. Burkle, for that. Our first panelist is Dr. Robert Wynn, who is newly appointed director of VCU Massey Cancer Center and was recently selected for the American Cancer Society's National Board of Directors. Now, Dr. Wynn was unable to join us live today, but he pre-recorded his comments for us. So you have the opportunity to practice in several different states throughout the United States. What common thread are you seeing in breast cancer disparities?
But if there's one common theme, I think that it would be that people still, women to this day, still aren't really aware of all that's accessible to them. And I think that that contributes to our disparities. There's also interesting misinformation that still remains out there, where sometimes women are getting misinformed that they can't get a mammography or that they can't get X, Y, and Z. And so I think the one common thread that I see is that we could do a much better job on making sure that everyone has the most appropriate, most accurate information, because I think that there's some missed opportunities, no matter what state you live in.
Again, this is Dr. Nguyen talking in these pre-recorded comments. Another question, how can VCU Massey Cancer Center and NCI designated cancer program impact change in the greater Richmond area and the entire state to reduce breast cancer diagnosis?
The 50th anniversary of the war on cancer started in 1971 under the president then of Richard Nixon. But Ted Kennedy was involved as well. That war on cancer led to the establishment of these NCI designated centers. We've been designated one of the early ones since 1974. So when I think about that, I think of how could we reimagine cancer centers so it can have bigger impact. And that is directly related to what I think VCU Massey could be doing today. And that is, instead of having folk try to figure out how to get to us, whether it's 120 miles. I used to say when I was in Chicago that even though it was 8 miles, people would have to sometimes take 3 buses and a train to get to us. And in fact, that reduces care. So in the 21st century, as I reimagine an NCI designated cancer center and our role, I'm imagining not having people get to us, but how do we get to them? And so you're going to hear from us a lot more strategies of how we make partnerships throughout the state. Partners with like the ACS, but partners with federally qualified health centers and other community hospitals of figuring out that if a person only has to probably travel 20 minutes to get care, and a woman has to get her care, and she only has to go 20 minutes away, it's more likely to happen that she'll take care and get that screening or get that mammography or get the care that she needs, as opposed to if you have to drive 3.5 hours. I care. And so I really want to make the 21st century cancer centers one in which we really do say we are focused and about the people. And the one way we can show that is having strategies of getting closer to where they live so that they can get access to care more frequently.
And one last question for Dr. Nguyen. When someone is diagnosed with breast cancer, what steps can that person take to be an active participant in their care?
Typically, when people hear I have the word cancer and cancer's attached to it, there is a freak out moment, understandably. But I want to tell you that since the 1970s till now, more women are living with breast cancer than dying from it. My job is to figure out how to get people to think and stop thinking about this as the big C and make that C just a little bit smaller with every passing year. So my advice, not only check your pulse and definitely be okay with the freak out moment, but know that there are people around you. The very first step is once you figure out and you've gotten that diagnosis and someone says cancer, the very first next step is to reach out to someone and know that in this state, that whether it's us, whether it's UVA, whether it's Monson, it doesn't matter, Riverside, please make sure that when you hear it, you don't just isolate yourself and suffer alone. We're in this together, and you have a team around you.
Very inspiring words. That was Dr. Nguyen. And as a lot of us know, our panel knows that he's on the forefront of this issue. So we thank him for his input. Now, some of the American Cancer Society funded research in Virginia is focused on breast health equity. ACS has 2 current research projects that we would like to talk about today. The first project is facilitated by Dr. Vanessa Shepard. She is the Associate Director for Disparities Research at VCU Massey Cancer Center. At Massey, she also serves as co-leader of the Cancer Prevention and Control Program. Her area of focus is breast health disparities in African American women. Dr. Shepard, based on your research, what can we do to prevent breast health inequities?
So, that's quite a loaded question, but one of the things I think we can do is to ensure that African American women receive the right treatment at the right time. So one of the things that we do know is that when the right treatment is received, we don't see some of the disparities when you compare Black and white women. And so that is something that is the focus of some of our research, is ensuring that we can facilitate that African American women are able to receive the recommended therapies.
Are there any actions that a person or a community can take to overcome some of these conditions, like, you know, where they're born, where they grow up, live, work, age, anything that they can control?
Sure. So if you think about particularly once women have been diagnosed with breast cancer, just starting from there are some things that are within control. And so we are working to develop tools for African American women specifically, because what we found is that when African American women have better encounters with their providers, so when their patient provider communication is optimal, then they're more likely to receive the recommended therapy. And that's in part for making sure that women have the tools they need to engage in those conversations, to be their own best advocate. And so that's something within the system. We can also ensure that our providers are able to communicate effectively, because we've also have seen that some providers communicate less with African American women compared to white women when diagnosed with breast cancer. And so from a system perspective, and also from a patient perspective, there's some things that we can do in that regard.
Now, I know you have received a research grant from the American Cancer Society. So how does that shape the work that you do? What do you use that grant for?
So this grant is focused to address some of the things that we observed in our observational studies around communication, access to treatment. And we did find that some women delayed in seeking care, but really when we examined it further, there were system delays. And so we are developing a toolkit through this intervention called Sisters Informing Sisters, where African American women that are randomized to this particular arm will receive a communication toolkit that we call Talk Back. And women are trained to tell their story, to ask questions, to listen actively, and to know their treatment options. Again, being informed helps you to really be able to think through what's best for you. They'll also receive tailored pathology reports. And we found that it was important that women understood when they received that report back from their provider, what's on it. When you see HER2 negative or positive, what does that mean? And so this study will test this comprehensive educational tool. And also women will be paired with a survivor coach. And so, you know, particularly in the African American community and in the faith community, there's this idea of sharing your testimony and overcoming through the power of the testimony. And so women will be paired with survivor coaches who have completed their treatment and have been trained specifically to deliver this intervention with them. And so that's what we'll be using these funds for, and excited to have this opportunity to do this study in Virginia.
That's a big project too.
It's a big project, yes. We're aiming for 400 African American women. And so this will indeed be one of the largest trials that's specifically focused on African American women. And I'll just say that the impetus for this really came from conversations with African American survivors and providers, and really in part from as well personal stories that I observed for women who had gone through this battle. And so this was something that was co-created with survivors and for them.
All right, Dr. Shepard, thank you. I know we'll hear more from you throughout the program. Now, the second project facilitated by Dr. Roger Anderson at the University of Virginia and Dr. Chris Lewis, who is at the Boston University School of Public Health, their area of research is focused on breast health disparities in rural Appalachia. So, Dr. Anderson, tell us how living in a rural area makes a difference in a woman's health.
Yeah, so, you know, it's actually on many levels, and really, you know, we really think of it in terms of this larger framework of life chances. And so even though you think about individual behaviors as owing to that person, you can decide what to do. What we really know about these risk factors is that they're very heavily influenced by where you live and the social group you're with. And so we know that in rural areas, we have higher rates of obesity, smoking, there's lower health insurance rates because of poverty and underemployment. There's decreased access to primary care in rural populations. And so this really sets the stage for, you know, going forward, not intervening on risk factors, not getting the regular and recommended access to, for example, breast cancer screening. And so it really sets up your risk or your chance of being a smoker, being at high risk for breast cancer or other diseases which could affect your health, like stroke and cardiovascular disease. But it also has other effects too. So there's the diffusion of innovation gap. So as new advances in medicine and treatment of cancer are made and approved and given to people, it tends to be the rural areas that lag in that uptake. And that's because they don't have the infrastructure, the professional groups there to actually do it. And then there's the old barrier of distance. It's just if you live in a low populated rural area, you oftentimes have to drive long distances to get care. And that distance alone, that 30, 40 miles, whatever it may be, itself is a really important barrier to care. And so we have to do more with telehealth and telemedicine to try to bring services to people, to really try to overcome that. And then I think the fourth, major theme that I'd like to emphasize is poverty. And we know, in any population in the country, that lower SES or having financial strain or financial need is a very important barrier to healthcare. And in rural areas, you have many places where economically they've been in decline for a number of decades. They have either a very limited employment base, and so there's higher unemployment and there's more poverty in rural areas. And so those factors alone, when you take those four things that I've talked about, higher risk factors, less innovation, more distance, and more poverty, you take that together and you cluster those in some of these regions like Appalachia, you really have this almost, worst case scenario. We have this toxic, set that you have to overcome.
Telemedicine can probably help with the distance, but how do you change the infrastructure? How do you go about changing that?
Yeah, well, that's a real challenge, and it's going to take more investment in primary care. I would start there because there are some counties in Appalachia that don't even have a primary care physician living in that county. So we have to begin with that. And there's been efforts over the last 10 to 20 years to try to get more physicians and healthcare providers, nurses, and other healthcare professionals in rural areas. I think it's had some success, but we need more investment. I still think telemedicine is a way to bring care to people at local centers like health departments and other public centers. I think we could do more than what we're doing, and I actually think COVID is going to push us, more to really do a better job of reaching people in their homes and in their communities.
That's a very good point. Dr. Lewis, if I can bring you in, what is the greatest impact you think your research will have on inequity?
Thanks, Reba. So our, you said Dr. Lewis, right?
Right.
Okay, just making sure. No problem. So I think our study is primarily focused on the breast cancer screening centers. And there's been a lot of research that is out there on individuals and on the populations, but there's been less that's been focused on the organizations that are providing care and the policies and the practices that are being implemented by these centers. So our study looks at 4 or 5 states in Appalachia, and we're drilling down to the level of the practices and the policies. So what are they doing in terms of quality? How many staff do they have? Things of that nature, to really understand what are the best practices. And we're going to do some further analyses looking at Medicare patients. And also, once we identify some centers that are performing at very high levels and getting screening rates that are higher than other counties, because we have the ability to map these things, we're going to go out and we're actually going to talk to the centers, and we're going to find out specifically, what are you guys doing that's different? What are your outreach policies? How are you getting into the community and engaging women and getting them screened at higher levels? And the hope is really that what we can do is we can communicate these things to other areas and provide resources or help work to provide resources and information so that other screening centers in areas that may not be performing so well can actually implement some of these best practices. So our study is a very practical, applied study that we're going to really try to peel back the onion and understand what's going on in the centers that are doing things really, really well. And what are the characteristics of those centers? Are they affiliated with large health centers, academic medical centers? Are they, multi-site locations? Do they have different types of things that are that they're doing to differentiate themselves from other areas? And as Dr. Anderson said, there are some counties that have significant, resource gaps. And how can we help outreach into those communities a little bit better?
And Dr. Lewis, I'll ask you the same question I asked Dr. Shepard. You also received a grant from the American Cancer Society. How do you think that's going to shape the work that you want to do to help these communities?
Yeah, so first and foremost, I'm a cancer survivor myself, and this work is incredibly personal. And I know, having my experience that I want to use the research that we're doing to help benefit organizations that are providing cancer care. They have tremendous challenges reaching out into their communities, engaging with patients. We can do better. And I feel like studies like this are a way to kind of advance those initiatives to really reach into the community to try to find practices and policies that are working and things that are relevant and ways that we can, create an environment where women can get screened easier. It's not just about, worrying about issues that are outside of our control. We can do things to remove barriers, and I think that we should do that.
Dr. Lewis and Dr. Anderson, thank you. We're going to hear from you later on in the program as well. Right now, in addition to funding cancer research, the American Cancer Society also provides patient services to people who are newly diagnosed with breast cancer. And today we have Cynthia Bruner, who is a breast cancer survivor and an ACS volunteer, to tell us more about her journey. How you doing, Cynthia? And tell us a little bit about your breast cancer journey.
Thank you so much. I'm so honored to be here as part of this panel and just talk a little bit about American Cancer Society. I would like to tell you a little bit about my own journey, and I think it's kind of important to begin there because my own story has deeply influenced my decision to become a volunteer and how passionate I've become about the American Cancer Society. So I was diagnosed with breast cancer just before Christmas in 2011. And that same year, I had experienced some significant losses. In February of that year, my father had died suddenly. And 1 week later, my husband had died of an intense brief illness. So hearing my cancer diagnosis for me felt like just a wave in the sea of grief that I was living in. My entire experience was changed by that and by my losses. And at that time, I would say, I went through my cancer surgery, my initial chemo treatments very, very stiffly and robotically. I just did whatever the doctors told me to do. I had some really wonderful support from my family. I have two brothers and my sister-in-law that helped take care of me and drove me to treatments and sat with me through those really long treatment days and made sure I had what I needed. However, living alone as a new widow and dealing with both the emotional and the physical effects of the diagnosis, the surgery, and then the treatments was very difficult. Unfortunately, I personally didn't connect with American Cancer Society for my own support, largely because I was barely emotionally getting by at that time. I'm really keenly aware now of how many people I interact with as a volunteer who also live alone and have very limited support systems. Their struggle is a difficult one, and reaching that part of the community is especially important to me. It is the heart of this Reach to Recovery program that I'm involved with for people facing breast cancer to feel less alone and less isolated. So if it's okay, I'll just go on and tell you about how I became a volunteer. Is that okay?
Yeah, please, go right ahead.
Okay. When my treatments ended and I began to feel better and get healthy, I was thinking a whole lot about what I could do to help and to give back. And for me, it was very personal because my husband had a really intense drive to help and heal the world. So it's something that we've talked a lot about, and we spent a lot of time in our personal lives integrating that. So after his death, that sort of became my drive, my own personal drive and way to survive. And I knew the American Cancer Society would be a place I could potentially help with nothing more than caring and my own personal experience. So toward the end of 2015, I looked into the programs. I found Reach to Recovery. I felt like it was a perfect fit for me. I completed my online training and became a volunteer in 2016. I had just a wonderful mentor who had been a volunteer and a volunteer coordinator for many years, and she helped me very much. And sadly, she died earlier this year, taken by a cancer recurrence. So I think of her so often, and I try to honor her with what I'm currently doing with Reach to Recovery. So the program, Reach to Recovery, for those of you who don't know, it's been around for a long, long time. It was introduced about over 50 years ago, and it's been evolving and changing to meet the needs of the community. But the mission remains so relevant. The Reach to Recovery program, trained volunteers provide what I consider to be essential emotional and practical support through the program, connecting directly with people affected by breast cancer, peer to peer, over the phone, online through chat and messaging, or via email. People affected by breast cancer can be referred to that program many different ways, through the community treatment centers, counselors, their providers, social workers, or direct requests they could call themselves, or their family can call the American Cancer Society. Earlier this year, we launched a new Reach to Recovery online website, platform, and a mobile app, which is super exciting. We have an active outreach in very many different areas of the community and different demographics in the cancer community. And I've been part of this new rollout for this new online program, and it's been really, it couldn't be more timely with COVID, as you can imagine. And I'm an active volunteer now. The program has come out of its pilot phase, and it's actively helping breast cancer patients every day. And I also serve as a regional volunteer lead in the state of Virginia.
It's like how you just paid it back going through your own journey. And I just have to say, for so many breast cancer survivors, thank you for telling your story, sharing your testimony, and just showing us your strength. So thank you so much, Cynthia. And we'll have more questions for you coming up.
Okay.
Well, the American Cancer Society sister organization, the American Cancer Society Cancer Action Network, works diligently every day to help pass new legislation and to keep funding for current legislation to help cancer patients. Now, one of the programs that we continually fight to protect is the Every Woman's Life program. And here today to tell us more is Fran Holcomb, who is a nurse educator with Riverside Health System Cancer Services. Hi, Fran, how are you? Can you tell us a little bit more about this program? I think you're on mute still.
Sorry, I got excited listening to the last speaker. Yes, in the state of Virginia, Every Woman's Life started in about 1997. It's nationally known as the Breast and Cervical Early Detection Program. And it's funded through the Centers of Disease Control and managed by the state of Virginia through the health department. And yes, the American Cancer Society has been a great advocate, as well as Cat B, about helping to keep the funding in the forefront. This program funds women who have no insurance, who are low income, and who may be at high risk for breast cancer or not high risk. But basically it funds it for women who do not have the needs of an insurance plan or even a provider, because we can also hook them up as one of the grantees. We can actually hook them up with a provider that will see them and manage them through that process. It's through the whole state. And if a woman is found to have a precancerous condition of the breast or cervix, I know we're talking about breast today, but it also covers cervical conditions. The General Assembly back in 2001 provided legislation that enacted the Treatment Act, so that if we get a woman with a precancerous or a cancerous condition, the burden wouldn't be on the health system to carry them through that process, but they would enroll into Medicaid, and it's a very short application process that I actually certify them, and very short-term process, and so that there's no gaps in any treatment process.
What particular services are offered for these women who qualify?
Sure, it's clinical breast exams by a physician or provider. We also do mammograms, pap smears, pelvic exams. And then if something is found from any of those, we also, in addition, will do diagnostic mammograms, ultrasounds, breast biopsies, and colposcopies for cervical cancer. For cervical surveillance.
So how do women find out about those services, find out about the organization? Is a doctor or a nurse or someone tell them about it?
Well, I can speak to that for my health system. We early on, we became a part of it in '98, and we early on sought out partners, faith-based partners, the Virginia Department of Health locally, all the free clinics we associated with them, because part of the process, you can have a program, but unless you go out and do recruitment where you let people know about your services or actually about the program. And we're all the case managers across the state are linked together, meaning that if we get a patient that calls that may be in another health district, we actually will give them that case manager to call. They can also go online to the Virginia Department of Health website. There is a state of Virginia number that they can call to also find out maybe which provider that they need to get hooked up with, who runs one of the grant programs. And there's a toll-free number as well as going on the website for those who do not practice any kind of internet, or because we have found that that's also a need, is we have to look at women, because our health system, it's in a rural and city area. We have both. So we have to look at how we can communicate to the patients in those different areas, whether it be, by the local radio station, that's all they use, to, advertising in newspaper and church services and things like that.
Yeah, I'm sure Dr. Lewis and Dr. Anderson are very familiar with that, trying to reach that population.
Yes.
Thank you, Fran, so much. We're going to talk with you a little bit later throughout the program. Right now, next on our panel is Iris Lundy, who is a director of health equity at Centera Healthcare. And let's talk about the work that's being done to identify disparities in our communities. Now, what is community health needs assessment? What does that mean?
Hi, thank you so much for allowing me to participate on the panel. So a community health needs assessment is an assessment that allows you to see the status of your community or its residents. So it's like a picture. It identifies key health needs and issues through data collection and analysis. It's going to cover things like population, employment, poverty, income, and education. And this is important because we understand that social factors are important determinants of health, which I believe was mentioned earlier by one of our other panelists that was speaking.
So, Sonny, how does this play a role in identifying breast cancer disparities in the Hampton Roads area for you?
Sure. So this document is it has resources and sources in one document in one location. It is widely available for the public to be able to see it. Each hospital or surgical hospital completes one. And what it does is, when you think about breast cancer, you can go to this one document and you can look to see where the burden of breast cancer is within your city or locality. And you can compare that to other cities and then compare that to the state. One way that we've been able to use this is that, when we look at it, we can see that when we look at Hampton Roads, breast cancer death rate and incidence rate is higher in our cities than it is for our state. And so then what it allows us to do is begin to say, okay, where do we need to focus our attention? And so we know that for those cities, we need to do screenings, have support groups, and provide education.
Like it can pinpoint like different areas of the city that may have more issues than others?
Well, there's another tool that we use that will help with that. But in this document, it's going to tell you, for example, that Suffolk, Franklin, Norfolk, Portsmouth, and it'll tell you their incidence rate and their death rate as it relates to breast cancer and other indicators also.
All right, thank you, Ms. Lundy. Now, we've all heard that cancer can be influenced by our genes, and to help us learn more about this is Dr. Lulu Rick-Santi, who is at Hampton University. Thank you for joining us this afternoon. What is genomics and why does that matter?
So thank you for having me today. Genomics is the study of all of the genes in the body. And so traditionally, we might look at how one gene can increase predisposition. So many of us have probably heard of the BRCA gene. Mm-hmm. We've probably heard about Angelina Jolie testing positive for the BRCA gene, or even Beyonce's father testing positive for the BRCA2 gene. Genomics takes into consideration all of the genes because there aren't just one or two genes that can predispose people to cancer. We now have identified hundreds of genes that can predispose people to cancer. And so genomics has led to the improvement of genetic tools. And now again, instead of testing for one particular gene, which was what we used to do 20 years ago, we can actually test for a panel of genes to determine if someone has a predisposition, a genetic predisposition to cancer, or could potentially have hereditary cancer.
And can someone overcome their genetic risk, or is it just something that you're born with? I mean, is there anything you can do?
Absolutely. So genetics is not destiny. And so one of the things that I talk about in the community is family history. And so I actually had a program last night teaching the community how to collect their family history, but also the importance of knowing one's family history. And one of the things, and one of the statements that I make that surprises people is that if somebody has a family history of breast cancer, let's say, the standard age for mammography is 40 years old for all women. However, if there is a woman in the family that was diagnosed with breast cancer at age 40 or before age 40, you're supposed to actually start clinical breast exams or mammography 10 years before the first case in your family. And so while we may not be able to prevent breast cancer in the family, the key to breast cancer and to all cancers is to diagnose it early. The earlier one can diagnose cancer, the easier it is to treat and the easier it is to manage. So genetics can help identify whether somebody's at risk so we can apply management and screening methodologies earlier in the family to find the cancers earlier.
That's a very good point. Now, your research looks at health equity. What are some of the key findings that you've discovered through all this?
So, my area of research is genetics. And so I'm really excited with how genetics has really improved how we manage cancer and how we treat cancer. And so there are a lot of genetic tools that clinicians can use in the clinic to develop a treatment strategy for that particular patient. So the right treatment for the right patient. But what we have to think about is who is contributing to the data and who is contributing to the development of these tools. And as we all know, minority communities and African Americans may or may not participate in clinical trials. So these genetic tools and these clinical tools are going to benefit those that participate in their design. And so my research it aims to improve the utilization of genetic tools, but also the utility, to ensure that these tools are representative of all of the changes that we find in all people. And so my research really aims to improve the diagnosis of cancer in African American women and improve the tools so we can improve the management of the disease in African Americans. So we want to make better and tools that will actually be helpful to all communities, because again, these tools are often beneficial to those that contribute to their design.
Very fascinating. Thank you so much. Thank you to all the panelists. So now I want to kind of open it up to questions from me and questions from the people who are watching us right now on our Facebook Live. We have a question from Caroline C. She says, exactly what do you think needs to be done to ensure that everyone has access to affordable, high quality, comprehensive healthcare? And we hear that a lot, access. Who wants to take that one? Maybe Dr. Anderson, because
yeah, I was just looking for my mute button here too. Thanks. Yeah, so that's a really complicated question. It seems very straightforward, but one is obviously health insurance, and you have to have insurance that not just covers hospitalization, but also outpatient care and other services. So that's very, very critical. And the other again is to have a regular. So all of the research that we've done on accessing primary care and how you prevent chronic diseases is having a regular provider that's or providers who are managing your care on an ongoing, continuous basis. So somebody's working with you. If you're a smoker and you want to quit, somebody's helping you do that. If you're trying to lose weight, somebody's helping you do that over a number of months. And it's not just going in because you're sick or you don't feel well. It's going in for a well visit. It's going in to make sure that what you're doing is correct and how can you improve. So I think that, and it's not just an individual's responsibility. I think it's a really important point is these practices that we belong to as patients need to reach out to us as patients and bring us into these. And so we need to see better programs within primary care systems that bring in people for well visits. And actually well visits are one of the things that the innovations of the Affordable Care Act, it began to cover well visits, whereas the older insurance policies, the pre-Affordable Care Act, did not cover that. It only covered illness visits, so you could only get services if you didn't feel well. So I think this is a really major thing, but it's not being taken advantage of enough to go in and have your well visit update. You can get one per year that's covered by insurance.
And Dr. Shepard, this is something that you touched on, especially the disparity between Black women and white women in terms of being diagnosed, and Black women die at a higher rate. And it's back to that word access again, and healthcare is one of those factors.
Absolutely. And I think it's a very good point when we think about all insurances are not created equal. And so we really want to have that comprehensive insurance. And particularly when you think about younger African-American women, where in Virginia, we are one of 8 states around the country where we have this higher incidence of breast cancer in African-American women. And so that access is important. I think it's been stated in terms of knowing your risks. Even in rural areas in Virginia, Black women fare worse. So sometimes when we think about rural communities, we forget that there are individuals of color and African Americans that live in these communities as well. One of the programs that we've been engaged in from an outreach perspective, not research, but through outreach, is working to navigate women in the Brunswick County area, which is one of the hot spots across the country for high mortality for African American women. And what we found is that some women didn't necessarily know how to access their insurance benefits. And these were people who some were underinsured or underinsured rather than uninsured. And a small number of the women who had not had a mammogram in over 2 or more years, they were survivors. So we really have to think about it, obviously, from that prevention access, and then depending on where people work, once you've survived the cancer, you may not have all the benefits that you need. And the last thing I'll just say about having a provider, we also want women to have providers that they trust. And so when you are insured, and Black women are more likely to be ignored when they feel something, right? So you think about the younger African-American woman, and many women have shared, their stories both publicly and in our research, that their doctors told them they were too young for breast cancer. So it's very important that you have a provider that understands your unique risk factors and that you feel comfortable talking to in terms of being an advocate and being able to get the care that you need.
Good points. Fran, I wanted to ask you, you're kind of on the front lines there. What are you seeing in terms of women? Are they able to go to the doctors on a routine basis, like Dr. Anderson was saying, but if they don't have insurance, what's life like for them?
It is a problem. If to access to care sometimes, and that's one thing that every woman's life tries to do, is to try to look at the barriers. What are the barriers? That's something as a case manager that I have to look at. Is it transportation? Is it that they live so far in a rural area we might need to purchase a gas card for them? Do we need to get them hooked up with a physician that in our health system, or are they more comfortable going to one of the free clinics that we associate with to establish care? So you have to look at it from the perspective of where that person lives, and maybe especially talking with them about what, sometimes we don't say, what are your barriers? You have to really just talk with that patient to figure out what kind of needs that they may be having. We see a lot with not only having insurance, but, fears, about going and having a mammography, or that they might find something, or because they've heard terrible things, about mammography. It's less now than when we first started because of the education everybody's been doing. We see less of those fears, but that's one of the things that we have to look at, as well as transportation, especially in our rural communities. We do try to help them establish a place to go and provide that transportation that they would need.
I think you made a good point about barriers, because I think sometimes when you're in it, you may not realize that you're facing a barrier until you
Right.
talk to someone and realize, hey, this transportation thing it's a big deal if you can't make an appointment.
Right.
The disparity right there.
Right.
Well, another question that's interesting, and the second question is about healthcare again, so I think it's on the forefront of a lot of people's minds right now. This is from Mackenzie J, and she asks, what are some steps we can take in healthcare and as a country to provide equitable access to healthcare and resources for prevention? A loaded question, but it's a good one. Who wants to take that one?
Hi, this is Iris. I'll start, if that's okay.
Right ahead.
So I think one of the things we have to do is understand that, care now has to become equitable and not so much equal. When you think about equal care, you're providing resources, the same resources to everyone the same way. But I'm an individual, and I do have individual needs. So care needs to be equitable, which means that I'm going to provide you the resources you need for you. And I think that, as a country, as a system, we have to begin to move in that direction.
That's a very good point.
So I'd like to add on to that too. I think from a policy perspective, there's more that we can do at a state and a federal policy level to increase access to screening sites and to prevention and preventive service for patients. Since Dr. Anderson and I have started this study, there have been a number of sites, even just since we wrote the grant, that have no longer exist for screening and leaving further gaps in areas in rural areas. I feel like there's much more that we can do to incentivize these providers and these health systems and independent practices to provide these services in the community. They're so critical to reducing overall spending across the country and improving outcomes. And screening is really the foundation of it. It's always that question: do you that we focus on as public health practitioners too, that, do you fix things when they're already going on, or do you really focus on the upstream and before the problems happen? And I think that's where more resources need to go right now.
I had a question about the coronavirus. Has that changed how we've done things or how you address disparities? How much has that played a role in it, this virus, and changing how we operate? I mean, even what we're doing right now has changed things. So what's different?
So I think that one of the things that we're concerned about is that that we may see cancers being diagnosed at a later stage, given delayed appointments, canceled appointments, the inability to even get appointments with the provider. And so some researchers have done projections. And so while we focus on the coronavirus, we also are still concerned about cancer, so that that doesn't exacerbate the disparities that we already see coming to the surface. So it is important that screening, obviously healthy lifestyles and things of that nature are important, but we are concerned that cancers may begin to be diagnosed at a later stage.
Good point. Anyone else want to tackle that question? Well, I'll move to the next one. This is from Pamela B. And she asks, how can testing for the BRCA gene be confidential so that health insurance companies don't charge you more or drop you?
So I can talk a little bit about that. So, the argument now about conditions, what's the word? The conditions that you had previously, those things are actually being argued right now as we speak. And so I wanted to put a shameless plug out there for the Cancer Action Coalition of Virginia, because one of the things that we do as a coalition, as a group, is advocate for our survivors, our previvors, and our community members. So, the goal is to ensure that genetic results aren't used against us and aren't used to raise the rates associated with insurance. That was a real fear many years ago when I worked in Washington, D.C. And one of the things that we were able to offer our patients in trying to address that fear is that there's the option of doing testing through research, because research results don't usually go into a patient's medical record. So we would often give the patient the option to do genetic testing clinically or through research, and coordinate how genetic testing is being done through our genetic counselors and through research purposes. So, those are things that are on the ballot right now as we speak. And so, as an organization, the Cancer Action Coalition of Virginia is trying to ensure that these things aren't used against our patients, and we're trying to advocate for our patients in that regard.
Good information.
And Reba, could I just also add that Title II has the GINA Act, Genetic Information Non-Discrimination Act, where employers is supposed to protect individuals' information to be used against them for employment discrimination. So I think that we can think about what measures that we have that may need to be expanded and also communicated to individuals, so that that doesn't become a barrier to them getting information about their risk status.
What is the name of that act again, Dr. Shepherd?
It's the GINA Act, so the Genetic Information Non-Discrimination Act.
That's good to know. And we have another question. This is coming from Linda M. She asks, please share information on triple negative breast cancer and why it's so particular to the African American population. And can you talk about the aggressive nature of the cancer, survival rates, the treatment? Are there any updates? That is her question.
So I can talk a little bit about triple negative breast cancer, because that's also the area of my research. So breast cancer can be described in many different ways. It can be described by the staging, how it's spread, how it looks, but it can also be described by the molecules or the markers that the tumor has. And three very important markers are receptors: the estrogen receptor, progesterone receptor, and another receptor called the human epidermal growth factor receptor. What's important about these little receptors or these little antennas or these markers is that they are targets for hormonal therapy. And so you can imagine if you're negative for the estrogen receptor, the progesterone receptor, and the human epidermal growth factor receptor, that the tumor becomes harder to treat by virtue of not having those little antennas. So one of the reasons that triple negative is so aggressive is because it's harder to treat because you don't have those little receptors. One of the things that I'm really that's really interesting to me, that I'm interested in researching, is why Black women have more triple negative breast cancer. And in fact, anywhere between 20 to 30% of Black women have triple negative breast cancer, compared to white women, around 10 to 15% have triple negative breast cancer. The reason that I'm interested in the genetics is because triple negative breast cancer is the most common type of breast cancer found in mutation carriers. And so my question is, do Black women have more genetic mutations that causes them to have more triple negative breast cancer? And so we can't really explore that if the genetic tools can't address the diagnosis or the finding of these genetic mutations. And so we think that there's some genetic predisposition that is increasing the likelihood that Black women have more triple negative breast cancer. But again, one of the reasons that triple negative breast cancer tends to be more aggressive is because you lack these markers or these little antennas, which make treatment of that cancer a lot more difficult to treat, or it makes it a lot harder. And there are other reasons. I didn't know if Dr. Shepard wanted to also chime in.
Sure. So I think this goes back to a couple of things. So when you think about one of the things that Dr. Rick Santee said earlier in terms of the participation in research and being able to develop the tools. So we've developed targeted therapies that better treat hormone receptor positive breast cancers, right? And so those cancers are the ones that tend to be in white women. And so in research, and particularly breast cancer research, much of the early research benefited white women because they were the majority in the population. They were the majority of individuals in studies. And so as a result, the treatment of triple negative breast cancer, even the characterization of it, really lagged behind what we knew was happening in primarily in white women. Now we know so much more. The primary treatment that's used for triple negative breast cancer is chemotherapy. Chemotherapy is actually effective. What we can't really distinguish is why about 50% of women with triple negative breast cancer will have a recurrence and do well and not do so well, and then the other half will. And so I think distinguishing that and understanding that from a genetic perspective is important. We know that there are some factors that are associated with the likelihood of triple negative breast cancer, such as being obese, waist-hip ratio. So there are some characteristics that are associated with triple negative breast cancer. We also know that it tends to occur in a younger age. And so when we think about the research questions that we ask, it really is important that we have questions that are really focused on the populations who could benefit or who may be disproportionately represented. What we also think about in terms of then what treatment are people getting? Everyone that's diagnosed with triple negative breast cancer isn't having chemotherapy. So again, so the tools that we develop matter. And then for the tools that we do have, at least can we work to ensure that people are having the treatments that we know do seem to be effective. And, you know, there is hope. The other thing we know is that African-American women are surviving after breast cancer diagnosis. So I know we're talking about a lot of statistics today. We're saying a lot of things about inequity, but for certain, you know, we are working to ensure that women have timely treatment, and we are seeing African-American women survive. And I think a question for us is to be able to understand, how is it that when African-American women, you know, despite the social determinants of health, despite the more aggressive cancer, these long-term survivors, what is it about their lifestyle, their environment, their treatment experiences that allows them to thrive?
Thank you, Dr. Shepard. I want to get in another question. This is from Tammy M. She says, I'm curious if there's any research on the value of having a diverse staff and impact of such the utilization of cancer services Meaning, does having an African American, Asian, Hispanic nurse navigators increase utilization of cancer services? Who wants to take that one? But having a diverse staff.
Yeah. So I'll talk a little bit. So I don't know that I've seen any research specifically on that, but I think just the fact that there are navigators present to help patients through navigate the system, overcome barriers, access resources that they wouldn't have, has been helpful in getting them not only to move through the continuum of care from screening to diagnosis through treatment and then ultimately into survivorship, but it helps them access the resources at all the different points that they may not know have existed. And I think if they find somebody who has in their local area, a connection with them or a similarity with the way that they have, what they believe and feel comfortable with, I think that's helpful. In the spirit of navigation, it's really about understanding the needs of the specific patient and trying to appeal to them, and then help them, leverage access to resources that they may not know about, and then bring those things to fruition so the patient can access timely diagnosis, timely treatment, and adhere to all of those recommendations that they have. They're long processes, and making sure that patients are engaged in the process and stick it through is very important. So again, not sure that there's any specific research on the diversity of staff, but I can only imagine that it helps build connections, especially with people who are in underserved or marginalized populations.
Very good point. Anyone else want to tackle that one?
Sure. So one of the things that we've seen in our research studies is that when we have had empathetic and culturally relevant or concordant research staff, we've had high participation from African American women in our studies, regardless of their socioeconomic background, regardless of whether they, the types of insurance that they had. And so I think it does matter. It can enhance. Is it necessary? We may not be sure, but I think it does matter. It matters in terms of research participation. I also think that it's helpful in terms of that communication. We do know that more African Americans and minorities are more likely to be in discordant racial encounters. So they're less likely to have an encounter with a provider that looks like them. And when they do, the communication is suboptimal. And so that goes back to this whole pipeline of what can we do. And so the more that we can have diverse individuals in the workforce conducting research, I think that we could expect then we would be able to have research questions and address some issues that may be relevant to those populations.
Very true.
And I also agree with Dr. Shepard. Our research has shown that having concordant recruiters, nurse recruiters, clinical researchers, and office staff has also increased our recruitment efforts into clinical trials, research studies, and even in just communicating cancer education information.
When I think about the cancer journey, I think about, the treatment, but there's also that support. Cynthia, I wanted to ask you, I know you were going through a lot when you were going through your journey, with your husband, personal things. Was there other support that you could lean on to help you through this journey, whether that was a nurse navigator or someone else or a support group, anything like that could help you during that time?
Sure. Yeah, that's a good question. I had a great nurse navigator who later we become very close friends. She was really there for me in a lot of ways for emotional support, and she helped identify some other services that were available to me that I had no idea about within the cancer center that I was getting treatment. So she talked to me, she introduced me to a social worker who I met with several times during my treatment, and she explained the process to me about having a team of doctors and nurses that sit down and go through the case of each patient that's newly diagnosed in that center every week. So she gave me a real understanding of what was happening in terms of guiding my treatment. So for me, that was a huge help. Unfortunately, I didn't reach out to the American Cancer Society for that kind of support, but I definitely received it at the cancer center level.
But that support is definitely available at the American Cancer Society for those.
Absolutely. And they have all different kinds of support folks were talking earlier, panelists was talking a lot about transportation barrier. And we have another program that is called Road to Recovery that helps facilitate driving patients to their appointments. And obviously with COVID, that's on hold right now, but that's a really, I think that's a super important program. I actually volunteer for that too, to take patients to their appointments. Just the simple act of taking away that barrier has a huge impact, I think.
So what are people doing during COVID if they have to make these appointments, and services like that are on hold right now? So what are they doing? A relative, or do you know?
Sure that the relatives are trying to step up as much as they can, but American Cancer Society will help with other forms of transportation if they can. That's not always possible, but sometimes an Uber or taxi service can be made available to them. I know that that has happened. I don't know that that's available 100% of the time because of the differences in the communities in the rural areas. Sometimes that's a problem.
So Fran, let me ask you, have you had to be involved in the support of these women as well? We talked about the treatment, but what about the support?
Meaning, you mean after they're diagnosed?
Yeah.
Yes, I work closely with another oncology nurse who's our breast navigator. Actually, we have two now, one in the rural setting and one in our more city urban setting. And we're close with them to transition them to a navigator, number one, because navigation is so important, like some of the other panelists have stated, because they offer services to them, usually free of charge. Ours are free of charge, and it just helps them to connect to the right individual, right services when they need it. It's someone to talk with at that, at that time when you may not have someone else, or you're not comfortable with talking with your provider. Almost anybody in oncology is very passionate about their patients, and so a navigator will connect you to the right individual or the right service that you may need. So yes, our Every Woman's Life patients who are diagnosed, we make sure that the navigator is involved, as well as myself. So they actually have two people that they can actually fall back on. And most of the Every Woman's Life programs offer that as well, a connection somehow. Ours is a little different because we hold the whole grant. Some are partners with grantees are partners with other health systems, so they may be in the health department, but they have a partner within the health system that they connect the patient with.
Thank you, Fran. And well, Iris, let me ask you, what can people do to support those who are diagnosed with breast cancer?
Yeah, I think there's several things we can do. One is stay connected. In a time like this where we're trying to physically distance, I do think it's important that we stay socially connected. I think the other thing that we can do is, just do it, right? I hate to put it that way, but for example, just go ahead and cut the lawn for them. It needs to be done instead of waiting for them to say, hey, can you cut my lawn? Maybe just go ahead and do it. Maybe go ahead and go grocery shopping and drop them at the door for them, those kind of things. And I think an important thing that we all can do, whether no matter where we are on this journey or how we're traveling with others, is to make sure that if we can, please give to those organizations who are doing research and who are working in the cancer realm.
Thank you, Iris, for that. Appreciate it. I do a lot of stories regarding breast cancer awareness through our Buddy Check 6 program. So I'm kind of aware of some of the disparities out there. But do you think the general population know that some of these issues exist, especially if you're not dealing with cancer yourself or a family member? Do you think the general population know what's going on?
Go ahead.
Is that question for any particular person or for the whole panel?
Anybody can take it.
Okay, so I think no. And let me just give you an example. So some of our work in Appalachia, we found, for example, that the rate of later stage breast cancer, and we define later stage as stage 3 or 4, So 3 is still not, a good breast cancer to have because the survival rate is only 75% over 5 years. So anyway, the rate of later stage breast cancer is 3 times higher in some of in the poorer counties than it is the more affluent counties within Appalachia. So who knew that such a disparity existed, a threefold difference. And that difference was accounted for in part, but not wholly, by the screening rates, by the number of healthcare providers that serve the area, and a number of social factors. So I don't think people realize that going from a threefold rate in later stage breast cancer is a significant health damage to that population and even to our country. And I'm sure it exists in other areas of our country. It's not just Appalachia. It's not just rural. It's under any underserved group is going to have huge disparities. And I don't think we've done a very good job as a nation in really describing these large differences. We know that mortality rates are going down, but they're not going down for everybody. And in fact, the rural mortality rates have really begun to plateau. They haven't dropped as fast as they have for other regions. So I think there's still a lot of education and awareness that we have to do about breast cancer disparities, and these are all treatable. These are all addressable issues.
There was someone else who wanted to chime in on that.
At large, probably no. When you think about in some of these communities that are most impacted by cancer, they also are dealing with other social determinants of health. And so I'm a cancer researcher, so I'm thinking about cancer. I'm not thinking about diabetes or heart disease, right? Or so unfortunately, some of these communities are hit with so many different things where it's like, what do I focus on first? And so I think that's something, even as we do our research focused on health equity, that I'm sure many of us on the panel have to also take into consideration. And then I just would like to kind of go back to what could people do is educate themselves. So if you're a family member of someone that's been diagnosed, to get reliable sources of information. It's very disheartening when a person's been diagnosed with cancer and they get random information from the web that counters the treatment that's being recommended, by your provider or your healthcare team. So I would just encourage reliable sources such as the American Cancer Society website, the National Cancer Institute, to get trusted sources of information so you can really support your loved one.
Good point. Anybody else want to add on to that?
Yeah, I think the other comment I'd make about the public being aware is that, to me, it goes back to the beauty of those community health needs assessments and with everything being in one document. And so, one of the ways you get that information is through focus groups. And so you have residents and patients and key stakeholders who are providing that information. And so if you're trying to figure out, and we use it to help prioritize what we need to do. So you can go to that document, and every hospital or your city has one. The Department of Health, I think, has one. Susan G. Komen, they have one. But anyway, what it will do is it'll help prioritize what's happening in your community, and it shows you what the community believes is relevant in their community. And then we can use that to help come up with interventions and innovations that can help us close this disparity gap.
And probably to piggyback what you were saying, Iris, and Dr. Anderson, you were talking about awareness. I think this is a good start right here. And I'm seeing some of the comments people are saying, where was this 4 years ago, having this discussion? How do you think we start to educate the general population out there of what's going on and to begin closing the gap? How do we do it?
Well, I think forums like this will certainly help, and we need more of them. And I think we have to realize that this goes beyond health insurance issue. We talk a lot about health insurance, and health insurance is very, very important, but it's not the only thing, because you see these disparities in insured populations. And why is that? And again, it's because the what I called earlier, the life chances. If you live in an area that doesn't have medical care, if you live in an area where there's high prevalence of risk factors, you're likely to have that too. So we have to do more than just provide health insurance. We have to have our health systems and our healthcare organizations do a better job of reaching people, finding how they can improve the health and not just treating illness. And that's, I know I've said that earlier on one of my comments, but I really see from from a preventive point of view that that's really where we're going to make a difference. I mean, certainly we have excellent therapies for cancer, and it's a travesty that not everybody gets those as they should, and we have to fix that as well. But I think that, again, getting back to the main point is I think health insurance is very, very important, and we all need it to be, to have access, but it's not going to be enough. And we have to change how health systems actually reach out to patients and give care.
I can add to that. Some of our successes to community outreach have been with faith-based organizations. I'm a firm believer in getting my team out there to say, let's go to where the people are. We can't expect the people always to come to us. And that's been a really big problem. We expect, we're going to put this on. And what's great about this forum, anybody can jump on if they have an iPhone or a cell phone. But there are some people in our rural areas who do not have those kind of things. But we try to go out to where the people are. And that's just a start. And build partnerships with people throughout the community that can help be advocates for us. I'm a big proponent of advocacy among people that you already go out and teach. So going to where the people are is very important.
Mm-hmm. Yes, and I want to piggyback also on what Fran was saying. For us, what has been very successful are partnerships and collaborations with the faith-based community and community-based organizations. Last night, and these organizations are in tune with the needs of the community. They often know what the needs are. And so we had somebody from one of the low-income housing communities come to me and say, hey, there is interest in learning more about breast cancer. And so these partnerships become very useful because, again, these communities are in tune with the needs. And so these academic and community partnerships are really important in disseminating the type of information that could improve and save lives in our community.
Hi, I also think it takes us to that trusted voice. So those community partners that Dr. Rick Santee was just speaking of, those are the voices in the community that the people trust. And so we need to lead on that. So, you have your clergy, you have NAACP, United Way, and other trusted voices, American Cancer Society, CACV, others. I think another great resource that's out there and that is open to the public is called GHR Connects. And so, you can go up there. It's available to everyone. It was created by some of the community partners just mentioned, and Centera. And so you can go and you can look at indicators, whether it's breast cancer or whatever. You can drill down to the zip code level and find out what's happening in your area. But also in that, it has these things called practicing promises, which is based on evidence-based practice. So it gives us ideas of things that we can try in the community to close some of these gaps. So that's an excellent resource.
Very good. Anybody else? We talk a lot about what needs to be done, but what do you think an area where we made progress, made a lot of headway in, that we're going in the right direction? What area do you think when it comes to disparity?
Well, one thing that I think has helped, at least at the primary care level, is greater use of electronic health records. And this has been able to, put more data at the fingertips, and you can search and find out who hasn't been screened in the last, 12 months, or are they due for something? And in the past, that was really difficult because people would look through charts to see, but now you can actually, for your whole patient panel, you can go and see what people need. And I think that's bringing us closer to that more proactive approach of making sure that we're all responsible for the care that people get. So I think that has really made a difference. And I think eventually we'll be able to link up a lot of these systems, and it's really hard right now to do that. But eventually we'll be able to link up systems, and so you can transport from a hospital to a primary care, and everything will flow. And I think that's on the way, and I think that's really going to help with care coordination and making sure that somebody has everything, getting all the elements of care that they need at that time. So I think that's been one benefit.
That's a good point.
I think that there's been progress in uptake of mammography, particularly when I'm thinking about African American women, and so that's definitely been an improvement. And in some places, African American women's rate of mammograms may actually exceed white women. And so I think that's an area. I also think that there's still work to do, but I've seen progress in sort of destigmatizing cancer. And so when you talk about going in some communities, that may not be what people want to talk about. There's been work towards educating individuals at younger ages, so in the school. So talking about cancer prevention strategies or sunscreen, or just adding discussions about cancer and health. And so I think that that's how we make progress, to just bring the education, knowledge, and awareness about it, so that people can have these conversations and don't necessarily feel that they should be ashamed or blame themselves if by chance that they are diagnosed.
Very true.
And another area that I think has made a lot of progress is in the area of genetic and genomic medicine and precision medicine. And so now we can essentially take a tumor biopsy and look at the genetics of that tumor, and the doctors can now prescribe a particular treatment based on the genetics. And why that's important is that there are some breast tumors that express markers found in prostate tumors. And so instead of strictly treating a breast tumor with breast cancer chemotherapeutics, you can actually treat it with this prostate cancer therapeutics, because it overexpresses, let's say, the androgen receptor. And so now we can actually target the tumor and provide what we call precision medicine and treat the tumor according to what it expresses. And it's no longer one size fits all. So you're probably seeing commercials all over the place now. If you have this mutation, or if you have this particular marker, this is the drug for you. And that comes from research in precision medicine.
Wow. We're getting, our time is winding down, but let me just sneak in one little last question here is 3D mammography. So when a woman goes to get a mammogram, should she ask for 3D mammography? Or the other one's just as fine? Who can take that one? Someone's going to take that one? 3D mammography?
So our site at the Massey Cancer Center, we are an NCORE site, minority underserved NCORE, and so we are engaging in research to really examine this issue and do some comparative effectiveness research. I was on a call earlier this week that suggested that 3D mammograms help with breasts that are dense, which tend to be more common in African American women. I think that the hesitancy and to recommend what, because it really depends on the insurance status. And so that kind of goes back to, you may have insurance, but you may not have access to, your copay may be different. So I think this goes to understanding, your breasts with your provider, and really getting the information to make that decision. And again, making an informed decision about, is it worth the extra copay or not? And knowing, the density of your breasts, I think that's very important.
Anybody else want to take that on? But I think the main thing is definitely getting women to get out there and get a mammogram. And I know sometimes there's different information out there. What age should women start to get a mammogram?
I can take that one. there are many schools of thoughts and many different guidelines. We've struggled here with what we should follow. I think number one, it's most important to talk, if you have a family physician, to talk with your family physician or nurse practitioner, whoever it may be, what's going to be right for you based on, you know, your family history, your personal history already, you know. But in general, it's recommended women in general, women over the age of 40 should start having mammograms every year. And we also encourage clinical breast exams before that. It's not always a recommended thing, but that gives you a time actually to discuss with your physician or provider what's going to be the best for you. But in general, age 40. But as Lulu said, or Dr. Lulu said earlier, you know, you have to look at if you have a family history of a first degree relative who may have been diagnosed in their 40s, you might need to start mammography, or you really should start mammography at 10 years before that person who was diagnosed. So if someone who had a mother was diagnosed at 43, they should start annual mammograms at 33. And that's another, it's so important to get established with a provider if they can, to have those important discussions. It also alleviates some fear and answers questions they may need to know.
Well, thank all of you so much for being here this afternoon. Thank all of you for joining us today on Facebook, out there watching us as well. And again, to the panelists, thank you for just sharing your knowledge, your experience, and your testimony, Cynthia. So thank you so much for being here. And if you enjoyed this discussion, we'd like to invite you to another virtual event coming up on November 9th. The American Cancer Society Cancer Action Network is hosting a policy forum. It is free to attend, but registration is required. Innovative researchers will talk about how their research will impact the way we prevent and treat cancer in the coming years. And please register and plan to join us again. That is on November 9th. And details are on the screen and available online in our list of resources as well. And again, I want to say thank you to our sponsors, the presenting sponsors, Virginia Women's Center and Dominion Imaging, our gold sponsors, Langley and Federal Credit Union, and our silver sponsors, Myriad and Centera, and bronze sponsor, Carillion and Humana, and the media sponsor, WTVR CBS 6. Again, thank all of you so much for joining us this afternoon. Appreciate it. Have a good one.
Thank you.